everyone, I hope you're enjoying your Thanksgiving vacation. I'm Valerie Cardenas, and together with Perla Friday, we summarized chapter 10 in the Gerhart book, which is titled Evidence-Based Cognitive Behavioral Approaches. So please bear with me, it's a fairly long chapter and there's a lot of information. So I'm going to break it down as easily as I can. So it may get dry in some parts, but again, I apologize. Okay, so evidence-based cognitive behavioral approaches discusses in detail two widely used contemporary approaches, one of them being dialectical behavior therapy and trauma-focused cognitive behavioral therapy. Both are evidence-based approaches that were developed for specific reasons and to treat specific populations. Dialectical behavior therapy is a cognitive behavioral treatment that was originally developed to treat chronically suicidal individuals diagnosed with borderline personality disorder. And it is now recognized as a gold standard in treating those types of individuals. But in addition, research has shown that it is effective in treating a wide range of other disorders, such as substance abuse disorder, depression, post-traumatic stress disorder, and then certain types of eating disorders. There are four components of DBT, one being a skills training group, individual treatment, DBT phone coaching, and consultation team. So DBT skills training group is focused on enhancing client capabilities by teaching different behavioral skills. The group is run like a classroom where the group leader teaches the skills and assigns homework for each client to practice using their skills in their everyday lives. Groups meet on a weekly basis for about 2.5 hours, and the session usually runs about 24 weeks. There's different types of sessions. It usually lasts about a year, but if any client needs to be refreshed in a certain type of skill, they can always go back to that particular class. DBT individual therapy is focused on enhancing client motivation and helping clients to apply the skills to specific challenges and events in their lives. In the DBT model, individual therapy takes place once a week for as long as 45 minutes to an hour, depending on the need of the client, and then it runs concurrently at the same time while they're taking the group skills sessions. DBT phone coaching is focused on providing clients with in-the-moment coaching on how to use the skills that they've learned effectively during situations that come up every day in their lives. So clients can actually call the therapist and speak to them in between the sessions, and the coaching comes at a time when they may need it the most. DBT therapist consultation team is intended to be therapy for the therapist, and it's to help support the DBT providers in their work with people who have severe, complex, and difficult to treat disorders. The team is designed to help therapists stay motivated and competent so that they can provide the best type of treatment possible for these individuals. The team usually meets on a weekly basis, and it's comprised of different individual therapists who are counseling people on DBT or using DBT, and each therapist is a group leader and then just kind of shares a responsibility and each client scenario so that they can collaborate and work together. DBT focuses on 4 sets of behavior skills, one being mindfulness, the practice of being fully aware and present in the moment. So that's one of the skills that's taught. Distress tolerance, so learning how to tolerate pain in difficult situations and not wanting to change it. Interpersonal effectiveness, so how to ask for what you want and say no while maintaining self-respect and relationships with others. And emotion regulation, how to change emotions that you want to change. The term dialectical means a synthesis or integration of opposites. So the primary dialectic within DBT is between the seemingly opposite strategies of acceptance and change. So for example, as a DBT therapist, we accept clients as they are while also acknowledging that they need to change in order for them to reach their goals. In addition, all of the skills and strategies that are taught in DBT are balanced in terms of acceptance and change. So for example, if you take the 4 skills that we talked about just a moment ago, they include 2 sets of acceptance-oriented skills. So mindfulness and distress tolerance are related or interrelated, and then the 2 sets of change-oriented skills, which are emotion regulation and interpersonal effectiveness, are related. Clients who receive DBT typically have multiple problems that require treatment. DBT uses a hierarchy of treatment targets to help the therapist determine the order in which the problem should be addressed. So there's a hierarchy of order here, and it's based on priorities. So the first being life-threatening behaviors. So first and foremost, behaviors that could lead to client's death are targeted first, including all forms of suicidal and non-suicidal self-injury, suicidal ideation, suicide communications, and other behaviors engaged in for the purpose of causing bodily harm. The second hierarchy or prioritized group would be therapy interfering behaviors. This includes any behavior that interferes with the client receiving effective treatment and can be a part of the client or the therapist, such as coming late to sessions, canceling appointments, or being non-collaborative in working towards the treatment goals. Quality of life behaviors or interfering behaviors. This category includes any other type of behavior that interferes with clients having a reasonable quality of life, such as a mental disorder, relationship problems, finances, or a housing crisis. And then finally, skills acquisition. So this refers to the need for clients to learn new skillful behaviors and to replace ineffective behaviors and help them achieve their goals. Within a session, presenting problems are addressed in the above order. And for example, if the client is expressing a wish to commit suicide and reports recurrent binge eating, the focus is going to be placed on the suicidal behaviors first. The underlying assumption is that DBT will be ineffective if the client is dead or refuses to attend treatment sessions. So that's the first priority, is addressing those suicidal thoughts. DBT is divided into 4 different stages of treatment, and they're defined by the severity of the client's behaviors. And therapists work with their clients to reach the goals of each stage in their progress towards having a life that they feel is worth living. So in stage 1, the client is usually miserable and their behavior is out of control. They may try to kill themselves or voice harming themselves. And so when the client first starts DBT treatment, they often describe their experience of their mental illness as being in hell. And the goal in this first stage is to help the client move from being out of control to achieving behavioral control. And in stage 2, they're living a life of quiet desperation. So the behavior is under control, but they continue to suffer, often due to past trauma or invalidation, and their emotional experience is inhibited. So the goal in stage 2 is to help the client move from a state of quiet desperation to one of full emotional experiencing. And this is a stage in which PTSD would be treated. In stage 3, the challenge is to learn to live. to define life goals, to build self-respect, and to find peace and happiness. So the goal in that the client leads a life of ordinary happiness and unhappiness. So it's understood that there's going to be some good times and bad times, but that it's kind of balanced out between the two. There's not just good times, and there's not just bad times. So for some people, a fourth stage is needed, finding a deeper meaning through a spiritual existence. And so Linehan has put in place a stage 4 specifically for those types of people. Someone who fails to meet a further goal of spiritual fulfillment or a sense of connectedness of a greater whole. So in this stage, the goal of the treatment is for the client to move from a sense of incompleteness towards a life that involves an ongoing capacity for experiences of joy and freedom. So from them feeling insignificant to at least acknowledging that they have an opportunity to feel happiness. So research has shown that DBT is effective in reducing suicidal behavior, non-suicidal self-injury, psychiatric hospitalization, treatment dropout, substance use, anger and depression, and improving social and global functioning. So there is evidence that proves this through different studies that Linehan herself has done, as well as different collaborators that she works with. So DBT, when done correctly or when done according to the principles, is definitely effective in assisting people with personality disorders or more difficult disorders. So the second evidence-based cognitive behavioral approach that was discussed in Chapter 10 is trauma-focused cognitive behavior therapy, and it's a components-based model of psychotherapy that addresses the unique needs of children with PTSD symptoms, depression, behavior problems, or other difficulties that can be related to a traumatic life experience like sexual abuse, domestic violence, or even loss of a loved one. So TFCBT, again, which is trauma-focused cognitive behavioral therapy, it incorporates interventions with cognitive behavioral therapy, family therapy, humanistic principles, and techniques, and so it kind of blends all kinds of different approaches together just to be able to help that specific child. Children and parents learn new skills to help the thought process, and then to kind of understand the feelings that they have because of these traumatic life events. The goals or the expectations of this type of therapy, again, are to help children and parents learn new skills to process the different things that come up with a traumatic life event. Also to help manage and resolve distressing thoughts, feelings, and behaviors related to these traumatic life events. And then enhance safety, growth, parenting skills, and even family communication once other things have been addressed. So the major components of TFCBT include psychoeducation about childhood trauma and individualizing relaxation skills. So the therapeutic elements of TFCBT are, again, psychoeducation and parenting skills, relaxation, effective expression and regulation, cognitive coping, trauma narrative, development and processing, in vivo gradual exposure, conjoint parent and child sessions, and then enhancing safety and future development. So those are the main focuses of TFCBT. So there's different sessions that can be done with TFCBT. One of them could be child specific. So during the child therapy sessions, the counselor focuses on relaxation training such as deep breathing, muscle relaxation skills, emotion regulation, which we talked about in the DBT side of it, a trauma narrative, and then processing or discussing the overwhelming events and associating feelings to it, as well as cognitive coping strategies, and identifying and then replacing negative thoughts if they have any that are associated with that particular life event. So another type of session that could be done is parent-specific sessions. So parents are going to, there's a correlation between how a parent copes with how the child copes. So typically the younger the child is, the better the parent copes. And then as they get older, it's kind of more difficult for the parent to cope with the specific trauma that the child experienced. So parents or primary caregivers are considered as essential therapeutic agents for improvement. And then during these sessions, the counselor discusses the appropriateness of the treatment, the safety plans, and then encourages positive parenting skills so that it can maximize the therapy itself between or with the child as well as the parent. So if the parent knows what's going on or knows the proper way to interact or the proper way to interact with the specific child, the therapist can, or the counselor can keep the learning going even at home. So things aren't just learned in the sessions themselves. The parents are instructed to continue that at home so that there's no lapse in learning. And then so parents and the child can also have joint sessions. So during the conjoint sessions, the counselor shares the trauma narratives and the challenges to incorrect negative thoughts as means to encourage and facilitate parent and child communication. And then the counselor could also intervene when inaccurate cognitions come up. So they're going to discuss with the parent and child what has happened in the individual sessions, and then hopefully establish lines of communication for the two so that they can continue to develop or have the skills necessary to overcome future